W pierwszej kolejności chciałam poprosić panią profesor Agnieszkę Michael. Parę słów na temat Agnieszki. Professor Agnieszka Michael is a distinguished clinical academic and medical oncologist known for her expertise in ovarian and kidney cancer. Her research focuses on immunology, clinical trials, and translational medicine, including pioneering work in cancer vaccines, viral gene therapy, and Hox gene research. She was the chief investigator for the TRIOP trial, a major national ovarian cancer gene therapy study. Professor Michael also holds leadership roles with the National Cancer Research Institute and the British Gynecological Cancer Society. As the medical director of the Surrey Clinical Trials Unit and the clinical lead for the National Cancer Audit Collaborating Centre, she drives innovation and improvements in cancer care. Her contributions have been recognized with the National Clinical Excellence Award. We would like to welcome Professor Agnieszka Michael. Clinical priorities in cancer treatment.
Thank you very much. Thank you for the invitation and a very kind introduction here. It's really a great pleasure to be here and to be able to give you this presentation. So the topic of my presentation is clinical priorities in cancer treatment. I'll just tell you a little bit about myself, literally 1 minute. So I qualified in Wrocław. It used to be known as Medical Academy. As you know, all medical schools in Poland were Akademia Medyczna. Now it's university. And then I came for personal reasons. I came to UK and did my medical rotation in various hospitals. And the busiest one was in the Old Church Hospital, which was, some of you might know it, one of those really busy DGHs where in 2 years you learn absolutely everything you need to know about acute general medicine. But this is also where I first came across oncology as a specialty. And I thought this was really special because although it was in a DGH and it was usually work with the last few months of people's lives, I felt it was a very personal and very special relationship with the patients. But to decide finally what I wanted to do I decided to then move to Londyn Hospital, and that really opened my eyes to the different part of oncology, so different side of oncology, not just the end-of-life care, but also the fantastic science and the very, very dynamic specialty that oncology is in cancer treatment. And I thought, this is what I really want to do for the rest of my life. So I then took on the specialty and spent the next several years training and doing PhD in cancer care, and that took me to my current job, which is at the University of Surrey and Surrey County Hospital. So when we talk about priorities in cancer care, I thought I would just show you this slide which gives you a cancer task force definition of priorities in cancer care, and it's very ambitious and there's a lot to be achieved. So obviously we're looking at cancer prevention. First of all, we're looking at early diagnosis, improved patient experience, but also commissioning and modernizing cancer services and a number of other priorities. But from the perspective of a clinician, I felt that for me, the most important were, first of all, better drugs and improving outcomes for patients, but also improving symptoms and better quality of life for people, and also maybe not adequate, but improving patient selection for treatment, and I'll come to that why I thought, well, I still think this is one of the most important reasons. So I spent a lot of time with immunology and immunotherapy of cancer. I think this is the most fascinating part of oncology, and did some research in cancer vaccines. And the concept of cancer vaccine may be a little bit unusual for people. We're all familiar with vaccination for viruses, for sort of infectious diseases, but cancer vaccines are perhaps a little bit more difficult to grasp. And the reason why cancer vaccines are designed, and the whole concept behind vaccination against cancer, is to enable the immune system to see cancer as something that shouldn't be there. The problem is that once the cancer grows in the body sort of stops seeing the cancer, the immune system becomes blind to it. And that's because nature adds up with the whole variety of ways. I'm not going to go into the complexities of that, but the immune system becomes blind to cancer cells and doesn't see it as abnormal. And then if you give a cancer vaccine as a new injection, so you usually administer what we call a protein or tumor antigen from the outside, then the immune system all of a sudden wakes up again and starts seeing it and builds immune response. But there's a whole science behind it. How do we design them? Do we give whole proteins? Do we give DNA? Do we give RNA? Do we give viruses as vaccination? How do we give it? Do we give it intravenously? Do we give it into the tumor or perhaps straight into the lymph node? When do we do it? Do we do it to all the cancers? And do we do it when the cancer is really advanced? Or perhaps it's better to do it at the beginning where there is no, or there is very little cancer on board. And these are questions that people have been obviously battling for years. So throughout my career, I had an opportunity to participate in a number of those trials and undertake research. So we looked at whole cell vaccination, so basically injecting cancer cells back into the patients, but there were cancer cells that were unable to divide anymore, so cancer cells that are irradiated but still deliver a whole host of tumor antigens so the immune system can wake up. And we certainly saw some immunological responses. It wasn't an immediate cure or even prolonged survival, but there was certainly a valid immune response. We then tried injecting vaccination directly into the tumor. So there were modified sort of gene therapy vaccines injected straight into melanoma or into breast cancer lesions. And again, you can see, not a very nice picture and very small, but you can see that some of those lesions were shrinking and there was a benefit to the patient. We then tried injecting vaccination into a different space. So I work with ovarian cancer, and one of the big problems in ovarian cancer is accumulation of ascites. So people have a lot of disease in this, what we call peritoneal cavity. And injecting virus directly into that has helped us control the ascites, and there were certainly some clinical responses. And the question that I've also been asking, and we've all been wondering, was the timing of vaccination. Would it be worth giving a vaccine when the tumor is almost not visible? We looked at, so this was a TRIOC study where we tried to vaccinate patients with a modified, genetically modified vaccinia virus, and give the vaccination at the time of the cancer was just coming back. So you could see either a biochemical progression or you could see a very tiny lesion on the CT scan. And again, we saw some responses. There wasn't a major impact in terms of overall survival, but there was increased time to disease progression. Now, the actual revolution in immunotherapy has taken place at the same time. It was a different route. So, as I've already explained, the cancer vaccination targets different tumor antigens, so proteins that are present on cancer cells. And those two gentlemen got a Nobel Prize for targeting not the tumor antigens, but targeting the immune system itself. And what they discovered, and what has really made a huge difference in oncology, is that you can block a break in the immune system. So what normally happens in all of us is that the immune system turns on in response to an infection, for example, in response to virus. It turns on into this very active stage, fights the virus, and then goes back to sleep. Now, if you inhibit the sort of natural way that immune cells switch off, then you can overactivate the immune system and make it work for you or for the cancer all the time. And that has hugely changed the face of immunotherapy, and we're now seeing cancers being cured that a number of years ago people would have died from. The problem that came with it is obviously people live a lot longer, and for many people it means perhaps cancer cure, but it also has a whole range of completely new and very difficult toxicities to manage, because a lot of people get autoimmune disease as a result of their vaccination. So from the practical point of view, what we now have is half the patients in the clinic come to get the treatment, the other half come to get the treatment for the complications of the autoimmune diseases that they have developed as a result of immunotherapy. So the choice of the right choice of treatment and deciding, getting the predictors of response, it's of absolute paramount importance here. Now the other part of sort of clinical, I call it as a clinical priority throughout working life of most oncologists is improving symptoms and quality of care and quality of life for patients. And again, working with ovarian cancer, probably the most complex and most difficult symptom to manage is malignant bowel obstruction. And it's not a sort of bowel obstruction where you, part of the bowel is blocked and you can just take it out or you can bypass it, but it's this disseminated disease, which is, the surgeons say if you try to operate and you open the patient up, you just see grains of sand throughout the whole abdominal cavity. And the whole bowel is smacked together and you just can't do anything, so there's no surgery, nothing that can help. And those patients come with very severe symptoms, severe abdominal distension, vomiting, they're very distressed about it. And the juniors and everybody, the seniors as well, have no idea how to manage that to make them more comfortable, apart from obviously painkillers and anti-sickness drugs. And what becomes the most difficult is feeding. And then, you know, in the ideal world, we would probably just commence everybody on parenteral feeding and let them go home and spend the last few weeks or months of life at home being fed through the tube. But the reality is that in England, this type of feeding is only available in maybe 2 or 3 centres. You have to have a certain life expectancy to qualify for that. So what you end up doing is sending people home on sips of water, which is extremely distressing for the patients, it's distressing for the clinicians. So together with a sort of dietetic team and very devoted team that I work with, we've been looking at an alternative way of feeding those patients using something called elemental diet. An elemental diet is made of amino acids rather than protein, so it is much easier to absorb and it absorbs higher up in the gap, so it can bypass part of that extraction. And we found that the quality of life for those patients and the burden of symptoms certainly can be improved. And then we followed that by doing a sort of self-management type of diet where the patients change their diet according to their symptoms and know how to manage them at home. And that allowed many of them to stay at home rather than being hospitalized. So apologies for the sort of small print here, but essentially we managed to cut down the number of hospitalizations and the number of hospital bed days to minimum. And the last clinical priority from my perspective is selecting patients for treatment. And it's not the selection, although we desperately need it, where you use a biomarker telling you whether the patient can respond to the treatment, but it's this sort of more personalized care and prediction of risks associated with treatment. As an oncologist, and everybody who practices medicine will come across people who will tell you, you told me that it's difficult, but you've never told me how bad it is, or even worse, if the patient dies within 30 days of chemotherapy or shortly after chemotherapy, the family comes and says, well, surely you knew she wasn't fit for chemo. And the answer is, no, I didn't. I really can't find a simple way to assess the fitness. And I've always been envious of my colleagues in surgery and in anesthetics who just take out their telephone and type a few numbers in there and they say, well, I'm sorry, but you can't be operated on because your risk of dying is 30%. Whereas we say to the patients, well, you might get a 1 in 1,000 chance of getting leukemia or 1 in 10 chance of getting mouth ulcers. So none of that is personalised towards patient, and that choice is often very difficult. And the inspiration came here from one of my colleagues who sent me a letter, a GP, who sent me a letter saying, well, could you see this patient? His EFI is this and this. And I thought, well, what's an EFI? I've never heard about it. And that's how I discovered this electronic frailty index. So that was published by Andrew Clegg several years ago now. But he published on an index that he automatically calculated from medical records. So literally with the press of a button, and it has 36 different fields where you look at very common conditions such as diabetes or falls or confusion or social isolation. And that allows to classify patients into fit, patients with mild, moderate and severe frailty. And then when we looked around to see whether there are any other sort of digital indexes, you can see here on the left-hand side that there's quite a number of those, and all those sort of different colours represent a different disease. But the reason why I'm showing you that is not for you to read it, it's just to show you the whole sort of variety of different factors that people take into account, and none of them is right. So we thought, well, why not try this electronic frailty index and see whether we can assess the risk of harm from chemotherapy. So I was lucky enough to get National Institute of NHR to fund the study, and we looked at 78,000 people with breast cancer, lung cancer, and colorectal cancer. And again, apologies for the sort of faint graphs here, but what it shows essentially is we looked at 30-day mortality, because this is generally accepted as the time where if the patient dies within 30 days, we think it's because of the chemotherapy rather than the cancer itself. And first of all, we see that actually quite a lot of patients die from chemotherapy, so although it helps, but 4.2% people died from chemo. And we had two different types of chemotherapy. So we had chemotherapy in preventative setting for breast and colorectal cancer, where patients had curative surgery and then only had chemotherapy to prevent the recurrence of disease. And we also had a treatment chemotherapy, so patients with lung cancer couldn't have surgery and they had chemotherapy to improve their symptoms. And interesting thing is that in preventative chemotherapy, so in breast and bowel cancer, the EFI is very highly predictive of 30 days chemotherapy. And sadly, if you probably can't see it in detail, but patients who are moderately or severely frail, they have 5 times as high a risk of dying from chemotherapy as patients who are fit. So, clinicians could then tell them, we can prolong your life by about 3 or 4 months, however, you've got 5 times the chance of dying from chemotherapy. That will give patients a little bit more information to make the right decision. Is this the right choice for me? It's not to stop anybody from having treatment, that's my job, I give people treatment. But it's to give them a little bit more information about what they're about to start. And it is certainly very useful in preventative chemotherapy. In patients who receive chemotherapy for treatment of the condition, such as lung cancer, it's still useful, but it's not as useful because the burden of symptoms that they have from the underlying disease is so much higher that all the sort of pre-existing conditions are no longer of that much importance. So just to summarize, to achieve world cancer outcomes, I think we all need to very carefully consider priorities. And we do have new cancer treatments. The new immunotherapy treatments are amazing and will make a big difference to people's survival. But equally, a lot of people develop life-changing complications. Symptoms and quality of life should always be a priority for all of us. And the careful selection of patients, which I think takes me very nicely into our next talk, should be a priority of everybody.
Thank you so much, Agnieszka. Would you like to accept this token of appreciation? That's
Thank you so much.
very interesting.
Fantastic, thank you. I have been hearing a lot about curative treatments in cancer, and you obviously know we see from time to time in the press colon cancer, mRNA vaccine, BioNTech, etc. Is this the next, or maybe this we will hear later, but is this the next step, the next phase of what you're describing?
I really hope so. I think if we ever going to get rid of cancer, it's going to be with immunotherapy and not the current treatments we have. And I was very excited to see the news on Oxford's ovarian cancer vaccine. I think the work is only just starting, but this is all prevention rather than the treatment, and I'm sure that's where most achievements can be done. So yes, hopefully that's the way we go. Yes.
Yes, I was just wondering about a very interesting talk. Thank you very much indeed. What about the role of metagenomics in patient stratification, efficacy of treatment, etc.?
I'm sure there is a role. I don't know very much about it, I have to be honest with you, but this is a major priority, is to find who benefits from treatment. So any form of biomarkers, and in immunotherapy there's again a lot of work ongoing to discover those biomarkers, whether it's through metabolomics, whether it is through circulating tumor cells or whatever. That's a priority, and there's a lot of work on that.
Thank you very much. Any more questions?
Just a quick one to follow on from Eva's question. So I thought that was really interesting, the work you were showing there on the elemental diet. And of course, you're aware of the work on arginine deprivation, also published in ovarian cancer. Is that something you're interested in manipulating to diagnose ladies with bowel obstruction?
So that's not something we've looked in, but it sounds very interesting, so I consider perhaps we can talk about it.
That was Bjorn's talk on our 75th anniversary.
Oh, is there an AHR?
No, it's about to be.
Oh, okay, well.
You can start Polish correlation on arginine deprivation.